So yeah, my talk really sucks without slides because I try to distract you with pictures and everything else. But quite honestly, all kidding aside, my discussion gets really dry. I'm going to water it down a little bit, but go through kind of the meat of it unless this comes on. Just because you could get lost in the minutia, so we're going to forget the minutia this morning. Anyway, my talk's on biologics and sports medicine, specifically what is PRP, what was PRP, what is PRP going to be, and the same thing with stem cells. So that's what we'll talk about. So we'll specifically talk about how they're used, how they actually work, what the evidence shows and doesn't show, and what's promising, and the reason it's not too worrisome if it doesn't prove certain things yet because so many patients do well. And obviously what we'll also talk about which way they're going, what direction we're going in. I almost want to flip this screen around, but most of y'all couldn't see it. So first off, PRP, platelet-rich plasma. Platelet-rich plasma is basically taking your blood, so it's autologous, almost no side effects, and using it as a biologic therapy. We're trying to get as many platelets as we can. The whole goal with PRP is to optimize the environment for tissue healing. So as a talk I went to several years ago said, I don't know if we can prove that it's the chicken or the beef, but we can prove it's in the soup. So PRP, stem cells later as well, you'll see, they're really trying to improve that collagen matrix, that cartilage matrix. They're really trying to improve the soup. PRP is basically, we take the equivalent, there's different amounts, but we typically take at least 20 cc's, which is about 4 teaspoons of blood. We spin it at 3,600 RPM for 15 to 20 minutes. We can respin it if we don't get enough plasma. And we're trying to get enough plasma to be 5 to 10 times above your baseline for blood. So I'll have a lot of patients tell me, why should I get it? Because I already have plasma. And my smart ass says, well, you're not getting better. So that's number one. And what we really do is concentrate it and using ultrasound if we need to really put it in the spot. Again, it's in the soup. What's in the soup? Tens of millions of growth factors. I used to joke in the era of steroids in baseball, these guys would kill to figure out a way to make these work because you would never be able to trace them in them. But tens of millions of growth factors that our plasma is used to help us heal. White blood cells to help us cure disease, plasma to help us heal. A little bit of white blood cell along with the plasma, some of it gets trapped when we spin it. A little bit is a good thing. Sometimes people think a lot is a good thing. That's where part of the research is. But all your PRP will always have a little bit of white cells in it. And we know for certain things like cartilage, the right amount of white cells makes a big difference. Again, it's autologous. It's from you. We don't add anything to it other than add a little bit of anti-clotting factor so it doesn't clot right away in the syringe. So low risk and obviously high biocompatibility. Not approved by the FDA. That's why insurance doesn't cover it. I mean, we're not exactly, my group's not exactly at the very forefront of doing things. We've been doing it 14 years and FDA doesn't cover it. But we're allowed to do it because we don't modify it, we don't change it into a medication, we don't really add anything to it, and it's low risk. There's no morbidity, no mortality with it. We used to think that as long as you gave people a bunch of growth factors, that they would heal, that the more platelets, the better, and it would actually repair the tissue. And in fact, PRP was used before. It originally came out in plastics especially facial reconstruction before we knew what caused it. But what we have found out is it really works through a bunch of different ways. The biggest thing it does is signal your cells to start getting you to heal. It improves that soup, so it helps with collagen and matrix synthesis. It actually stimulates new blood vessels to form. My example is it's really hard to grow grass if you don't water it. So if I get your cartilage to repair, it's not going to repair real well if it doesn't have a fresh blood supply, and it stimulates that. We know the big thing where people feel a difference, whether it's healing them or not, is it really cuts down on inflammation. And that's kind of the biggest model that you can prove with PRP, stem cell as well, that's what it's doing. So instead of just making healing quicker, don't fall, by the way. I don't have to show my slides that badly. Instead of making healing quicker, it optimizes healing. So that's the way it works. So we do know that it depends on the amount of platelets you put in the system. We don't know how many is too many. As of right now, the more the merrier. There's not a law of diminishing returns just yet. We know that the white blood cell content, you want a little bit. Sometimes you want a little bit more. We're still trying to figure out what helps what. There's methods to activate it. You can add certain things like thrombin and collagen that'll really activate PRP. We're trying to see what the role is for that and what that means depending on whether you want to get tendon or ligament or cartilage to get better. We're finding out as time goes on that the type of injury, the age of the injury, the age of the patient, the activity of the patient, all of this comes into play. So that all has the factors. What's interesting is some studies actually show that it inhibits healing. And so it shows you that the studies are all over the place, but people tend to tolerate it well. PRP is in general is used for, as the stem cells, tendons, ligaments, and cartilage. Tendons, PRP works best in chronic tendinopathy, so like a chronic tennis elbow works really well in grade 2 and grade 1 partial tears. Ligament, it seems to give good support for healing. Remember, it cuts down inflammation so they feel better. So ligament, really studied in the UCL of the elbow, does real well with grade 1 and grade 2 injuries, really preventing Tommy John, because we used to Tommy John all the grade 2s that weren't getting better anyway. It can help with MCL and ACL injuries. When people are having trouble with their cartilage, it can definitely cut down inflammation, help with repair. How much it repairs is different in everybody, and we don't really have a good answer for that. People that have early wear and tear, even the people we take care of that have early arthritis, they seem to get the best use for it. If anything, it seems like it helps your cartilage work better and maybe help it thicken. We're also starting to use it a lot more in surgery. You can ask Dr. Schmidt. He tries to get everybody to use it immediately post-surgery before they're out of the OR. They feel a lot better, a lot quicker. It really cuts down on inflammation, seems to cut down on bleeding and swelling. I think that has a lot to do with again, the soup, reducing the inflammation. And again, it tends to be safe. You know, we use it a lot for tendons to treat tennis elbow, golfer's elbow. It's really successful with a chronic Achilles and chronic jumper's knee. And really successful with people that have chronic rotator cuff problems as long as they're partial. All of these would need an ultrasound. We don't just want to coat the injury in PRP. We actually want to put it in the tear. The rationale behind it is these tendons, relatively speaking, have slow intrinsic healing due to poor vascularity. It seems that the research shows that it improves that vascularity, just like we talked about before, and really gets everything lined up, everything ready to roll to heal. The nice thing is that most people report pain reduction and improved function, and that's what really we're going for, even at the highest levels. In ligaments, again, it's studied mostly in UCLs of the elbow. It does seem to help in partial ACLs, but they have to have no meniscus tear, no bone bruising in their knee. It has to be truly an isolated ACL. I've used it a lot for MCL and LCL injuries. And yes, in case you're wondering, yes, it hurts. But typically, if people need a second one a couple of weeks later, they'll feel so much better that they're not only asking for the second one hurts a lot less. And we're not cruel. We do use local anesthesia. So anybody that has a complete ligament tear, this is not an adjunct for that. While you might use it to reduce inflammation, they still need that tendon repaired. Really with partial tears, if you think about it, it already has the scaffold there. You put it in the partial tear, it's building on the scaffold. With a complete tear, it doesn't have that. But for the even the high-grade partial tear, that seems to do a good job. There are a lot of reports on how people do with high performance. And so anecdotally speaking, I've had a lot of athletes go back to pitching for the high school and collegiate baseball teams, soccer players coming back after a bad hamstring, and in this case, after a bad MCL, coming back quickly. And so we have reports, we all share stories, but there's no randomized clinical trial saying we gave these athletes this, we did this with these athletes and so forth, and people, and to be able to compare how people are doing. I don't know a lot of athletes that want to be in the guinea pig section that said, let me see if you can get me better quicker or not. So the biggest trouble with a lot of these trials is nobody's going to volunteer for them. Everybody wants the good stuff. So last things that PRP is used for is cartilage. Real good success with anybody that has any early wear and tear. It does not reliably regrow cartilage at all, but it definitely reproduces pain, and they'll typically do good indefinitely for years at a time. Seems that it stimulates the beginning cells of cartilage, chondrocytes, which produce a lot of factors, their own growth factors that help heal. So it really starts that domino effect, and that's what seems to happen. They're really looking at with people that have a cartilage defect, a cartilage divot, a meniscus tear, how it works with the scaffold, with some kind of polymer, with hyaluronic acid, which is the rusticome injections we do for arthritis. It seems to work better. It's a little bit of a mixed bag, but that's where a lot of the studies are going to. So what we know about PRP is it's safe. The reactions to it are low, if they're even existent. Real promising for tendon injuries. Seems to work in certain ligament injuries. The tendon and ligament injuries seem to do good if they're chronic, seem to do good if they're partial, but not if they're complete. And then structural healing of a muscle and so forth, there's a bunch of mixed outcomes. I can tell you it's a little bit hit or miss. In my experience, if I have an acute muscle strain, I treat it like an acute muscle strain and they do well. But if I have a grade 2 hamstring strain because of a grade 2 injury to the tendon, those athletes seem to do better quicker. And so definitely where you put it, where the injury is, the age of the injury and so forth, that's what really comes into play. Really the limitations with the studies of PRP, because it's significantly more affordable than stem cells. It's more available. People really like the idea of using their own blood, and we do it within the same office visit. We don't doctor the blood up at all. But there's no standardization of how long do you spin it, how quick do you spin it, what should your centrifuge look like. We don't really know what the true platelet concentration should be. Again, we are following the adage right now of the more the merrier. But we know that a cartilage is probably different than a ligament, than a tendon. Articular cartilage different than meniscus. And so that's where they're trying to see the differences. They're doing that as well with the inclusion of leukocytes or white blood cells like we talked. They're also looking at injection timing. Do you give it immediately? Do you wait a while? Do you wait a week in between injections? Do you wait longer? Do you wait to see healing? So that and the number of doses, all of that comes up. But it seems to work just very limited in real high quality random trials like we talked about. So what everybody's going for now with PRP is standardizing protocols, figure out what the dose should be, figure out what the platelets should be, figure out how much white cells to include. They want to actually develop a classification system for how you do it, and that would actually help reporting as well. They're really looking at combining it with stem cells, with the scaffolds we talked about, including the hyaluronic acid. And is there a way to personalize it? A lot of this is getting into AI models to see what works better for who. Is there a difference when you're in your 50s versus your 30s, what your activity is, and so forth. So under investigation right now is not only that, but they're really starting to look at it with stem cells specifically for cartilage regeneration. They're looking for controlled release models where you give it and it slowly releases over several days to a week or two. They're starting to use it a lot, specifically with meniscus repair in the OR, to see if it helps them get better quicker. As most of you know, people that have the meniscus stitch take about 3 months to get better. First month on crutches, so we're trying to see if that can help that and so forth. So probably some of your key takeaways from this, skipped a couple slides, I get too into it, but your key takeaways from this is it's safe because it's an autologous biologic therapy. It's healing modulation. It really preps healing. It's not just healing acceleration. Tendons it works really good for. Oh my God, we have life. I'll even take it with that black screen in front of it. I'll figure it out around there. And we're really looking to improve how it heals ligaments and cartilage, even though it seems to work well. The biggest push now should be to standardize it, to personalize it, and to combine it with something. And I think that's what you'll see in the next 5 years. I'll give you a little bit of my experience kind of at the end. Are y'all able to forward those slides at all? I'm going to take that as a no. But this means that you have hope for later. Oh, hold on, we're trying. Who can forward the slides for me? Everybody ran away. Is there a way for you to forward the slides for me? Since I'm not on that slide. By the way, I'm not worried about time. I always build in buffers for times in my talks. And like I said, it sucks without the slides.
Which slide are you looking at first?
That one's the first one. I'm on one called What Are Stem Cells, which is about 2/3 of the way into it.
She's working on it.
We'll wait. Back when I was growing up, this is about the time half the room would light a cigarette. And there would be ashtrays in your seats. That's a long time ago. You know what? I'm going to give them a couple minutes. We're getting there. Yes. Yeah, so we use PRP for tendonitis when it won't go away. I'm always very conservative. I want to treat first. But we'll use it, and it seems to work well. And it probably purely works good because, in my opinion, it's a better anti-inflammatory than steroid. And it's a hell of a lot safer. With a tendonitis? Well, return to activity for me is always going to be do what you tolerate because you're not torn. But I would tell you that when we tend to treat with that, it tends to cut the recovery time in half. So an Achilles recovery time is more like 3 months. A tennis elbow is more like 6 weeks. And so that's always hard, it depends. And then obviously you get into activity, how heavy, how good a shape in, what's the flexibility, what's the strength, do they have diabetes, there's about 1 trillion things that come in. But in general, I will tell you better quicker and better longer. So we don't see a lot of recurrence even in an older population.
Over the steroid injections or the cortisone?
Steroid injections, I'll give you an idea. For your patellar tendon, you don't get one.
But I mean for like your CRB, your elbow.
Yeah, so for your elbow, you get 2 max. And when we're going to the third one, minimum, we're getting an MRI. And you're more than likely meeting a 10X procedure or Dr. Bag in Dr. Green's office. So, am I able to forward this? I guess I'll find out. Anyway, so this is the last part. Hold on. No, I'm not able. Go to perfect, and I'll tell you when to forward it. Thank you. So I'm going to leave it there. I have a slide before that. So stem cells are unique cells capable of self-renewal, and they can differentiate into specialized cell types. That doesn't mean that's what they're doing in your body when we inject them, but that's the definition of stem cells. The sources we have are either autologous. We get the stem cell from you. We either do it from your bone marrow. You can get it from the tibia. You can get it from the pelvic crest. Yes, it hurts. There is a lot of studies, and we're going to start branching into actually getting it from fat in your flank. That doesn't hurt quite as much. That's a simpler procedure. Yes, it's kind of like liposuction. No, it's not liposuction. And what you do with the adipose tissue, myself and Dr. Santa Maria were part of a study probably 15 years ago now with severe arthritis. What you do is you isolate it. It takes you about 45 minutes to isolate stromal cells that are very, very similar to stem cells, stem cell-like. They're considered stem cells. And you inject them into the knee, and it's had really good success. He's still part of those studies moving forward. We do a lot of purchasing of stem cells, and those are allogeneic stem cells. The ones we use are typically amnion cells. They can come from Morton's jelly. There's a bunch of different products out there, but we tend to get ours from FDA-approved companies and labs. It's a lot more straightforward, and as of right now, a lot less expensive. To harvest bone marrow, to harvest adipose tissue is a little more expensive, and obviously less discomfort everywhere else. The stem cells we usually talk about whenever you hear that word mentioned in anything are called mesenchymal stem cells, MSCs. They can literally become anything you want them to. Again, that doesn't mean they do. when we inject them, and that's what we're trying to find out, how to turn that switch on. The amnion cells have all the growth factors that we talked about. They do have stem cells in them, whether they're alive, whether they're dead, whether they contribute. That's where all the studies go into. So they're not necessarily live stem cells, but they typically have a high success rate. Next slide for me. So what we used to think is, hey, you put the stem cell in there, if the bone's damaged, the stem cell is going to know to be bone. Cartilage is damaged, it's going to know to be cartilage, and people will do well. What we have found out is that's not how it works at all, even though there's a lot of other things that can happen. And so what we know is very few of the stem cells are live. At least it's been hard to prove them. It seems like the presence of stem cells work, but if you remember earlier, I said that one talk I went to said the soup is really good. If we know that if platelets in that vial that you saw of PRP, if that has tens of millions of growth factors in it, stem cells will have hundreds of millions in them. And so they're still trying to figure out the role of the stem cell. Does it matter if it's live, dead, partial? Does it matter if you froze it right away or you did somehow else to harvest it? But they know that certain other products with it work. I put on here that cells can become senescent and damaged. Senescent comes from the same root word as senile. So there was a study done a handful of years ago that said that human beings' stem cells harvested from their bone marrows start to become extremely senescent at the age of 29. And so we remind people that we don't really know if we should be using these when they come into the office for this. The clinical benefit, again, is likely from the reduction of inflammation. We'll talk about how else they work, but it's probably not because it's the stem cell growing into the different types of cells it can. Next slide, please. The way they work is that they secrete their own factors that stimulate your cells to heal. And so they will signal it, they will reduce inflammation, they will make the process better to heal. That's what immunomodulation is. And then they serve a supportive role as well, not only recruiting other stem cells, that may be part of the mechanism of how they work, recruiting other cells for healing, that may also be part of the mechanism, but in controlling inflammation and everything, they support healing as well. Next slide, please. This is commonly what it's used for. If you see a lot of crossover with PRP, tendon, especially again, Achilles, rotator cuff, you can use it for chronic tennis elbow, chronic golfer's elbow. Ligaments, the same ones we talked about before, including UCL. Cartilage injuries, including meniscus and any kind of wear and tear, any kind of cartilage defect. Definitely helps significantly in bone healing if you can get it into the matrix. And it seems to really work for discs, although I've yet to figure out who's a candidate for disc problems or not. But we have quite a number of patients who fail epidural steroid injections that do really well with 1 to 2 cell injections. Next slide, please. So similar to PRP, tendons and ligaments tend to heal slowly. It has all to do with vascularity. And even an 18-year-old athlete will have some wear and tear, some chronic Achilles tendonitis and so forth across it. It enhances the healing environment. We actually think it stimulates a process to clear away some of the tendinopathic, the inappropriate scar tissue, and replace it with better tissue. So we know that improved pain and function for sure. If you read papers, just case studies of people saying, I did it for this athlete and this, there's no doubt that it seems to make a difference. Not all the time, but quite a number of times in general. Next slide, please. So here are the challenges we have with cartilage and joint use. Cartilage, again, has limited natural healing capacity. Usually we do surgical repairs, and the surgical repairs will make them more functional, but they're not always 100% successful and return them to new. So versus a tendon or a ligament injury, you just have to put this in the joint, let it coat the cartilage, and they tend to work real well, not only for pain, but for function. And again, they're looking at scaffolds. If we can put it on a substance that stays in a certain area a little bit longer, whether it's something synthetic like bioglass or PEG, or it's hyaluronic acid or collagen, if it'll work. Next slide, please. So where we stand today is a lot of animal studies in stem cells for every disease process, not just orthopedic. Human trials, again, tend to be limited for the same reasons that the PRP trials were. There's not a lot of randomized trials. There's really not any standardized protocols, especially for us that purchase our amnion cells. The protocols are varied from collection to storage to processing. Some are powdered and you can keep on a shelf. Some you have to put in a deep freeze that measures temperatures in Kelvin to keep it frozen and defrost it and so forth. And so there's a lot of different protocols out there. They all seem to work pretty well. They all seem to work pretty well for a lot of orthopedic problems. Again, the big thing is how do they work? Do they regrow and so forth? We're still trying to figure all that out. Next slide, please. And the last thing on that last one I didn't mention is some clinics market improvement treatments. We as physicians get in trouble for that. So we cannot market, come on in and it'll heal your tennis elbow, it'll heal your arthritis. Every now and then, if you'll look, I actually put quotes around stem cells because we are actually not allowed to use the word stem cells when we're talking about these injections. They are amnion cells. If you're getting them from somebody, you're using stem cells, but we have no proof of what the stem cell does. And so very, very frankly, that's an FDA no-no for us. And our marketer sitting here, Lily, she knows in all the marketing we put out. We actually even send it to an attorney to make sure it looks okay, because they're real big sticklers, because the research in the end hasn't really shown anything specific. We just know how a ton of people are doing. Anyway, so they're looking at scaffolds and with the cells. They're looking at different types of cells and making them very specific for the injury, for the age of the patient, for the location. Do you treat cartilage in the shoulder different than you do in the knee or hip? And they're getting into different types of stem cells to do that. That's where the bioengineering, that's where the AI comes in and so forth. They have definitely been looking at for a long time what happens when you add them to PRP, what happens when you add them to PRP with a higher content of white cells, with a lower content of white cells. Should you do a PRP, the second injection, a PRP with cells, the third injection, just a PRP. So they're looking, you name the combination, they're looking at it, trying to figure out what that on switch is. But definitely what we're really moving for more than anything is being real targeted in our repair and have it regenerate. I mean, this will solve a ton of issues in orthopedics. And I just think it's a matter of time of figuring out that on switch again. Next slide for me. Maybe. Thank you. And so here it is in the end. I can shout if this doesn't work. Here it is in the end of how cells work. So remember, they modulate inflammation. They signal local cells to help you repair. And they try to stimulate your body to make new tissue. A couple of studies out there suggest some people grow a little bit, some people grow a lot. These are done with MRI, studied over years. But nothing ever says everybody grows. And how do you know who grows a little bit and a lot? But that's basically the way they work. Next slide, please. Can you all hear me? I'm used to yelling out my voice. Very, very promising tool. I think we're going to find a good combination with PRP and stem cell. We already went over the signaling and how they affect the immune system and inflammation in a positive way. We can use them in everything in ortho, both of them. One of them might be more promising than the other, we'll find out. And one thing is for sure, people are trying to study them and trying to get out there what we can. But remember, studies are done over years. This is a very slow process. And in the end, studies cost a lot of money. And these are expensive tools. So I think we'll all see, hopefully in our lifetime, I don't know, I'm getting up there. A couple of you are getting up there too, I see you. But I think within my lifetime, maybe not my career, we'll see them really, really influence how we do. And with a lot of you athletic trainers that I've worked for years, you know how we can really change injuries, especially bad injuries with it. Next slide. So I was originally thinking you guys were going to get your peptide talk this morning. It's tomorrow morning, I think at 9:15. And so they will go into real specifics with peptides. I have a lot of patients who think peptides are forms of stem cells, and they're not. So peptides in the end, PRP, you know that, stem cells, you now know that. Peptides are short chains of amino acids, and what they do is they signal cells to start doing specific functions. So if peptides direct, PRP activates, stem cells activate and attempt to regenerate. And that's really the big difference. Next slide, and I think that's it. Oh, my opinion, that's right. So, if you talk to my partners, you'll get different opinions, but the majority of us, I think, share this with either PRP or, as you see I put it, stem cell. Grade 1 to 2 ligament injury, partial injury, same thing with tendons, seems to work real well. I have a lot of good success, personally speaking, with 2, sometimes 3 injections, ultrasound guided for the proximal hamstring. I've never seen a grade 3 in a somebody that's professional, college, high school level of athletes. I've treated a lot of grade 3. They hate to be called non-athletic population. They're athletic, they're just not in an organized sport. They're trying to be active. They help them significantly. They cut their time in half of healing. They've done really, really well. They really don't have any long-term symptoms. Certain cartilage injuries, it can help. Certain meniscus tears, it can help. The meniscus tear, if you have to do an MRI later, always seems to look better, but I can't tell you that it really heals, but it can help. Some people still need surgery. And actually, I'll have people come in with chronic, thank you, I'm gonna lose my voice. I'll have people come in with chronic calf tears, chronic hamstrings, and we'll actually put it in the muscle themselves. We prove it by MRI first. We do it all ultrasound guided, and they do well. Parents really like to do PRP versus any other injection if their kid is not getting better, especially from a cartilage injury. You will have a chronic runner's knee, an OCD, an osteochondral dissecans or defect that healed, but they're still having symptoms. Some of our patients, because of multiple patellofemoral dislocations, you'll have early patellofemoral arthritis. I've never found a parent say no to at least trying one PRP injection, because to do it where the kid doesn't want to do it, because it's 2 sticks in 1 day, but they do really, really well. You're using their cells. And in almost everybody, for me in the pediatric population, 1 injection, they're golden. They're a lot better within 2 weeks, and they're blowing and going within 6 weeks. So 2 injections sometimes in adults. And we preach all the time. Dr. Cauthen, one of our fellows, is here. He's probably sick of hearing me talk ultrasound. The ultrasound makes a big difference. To put it in there blindly, that to me is where maybe it works, maybe it doesn't work. But if I could put it in a partial rotator cuff tear, partial Achilles tear, if I could put it in there specifically, it can make a big difference. Next slide. That should be it, because I run out of knowledge at a certain point. Any questions? Quick couple. Yes, sir.
Is insurance covering these treatments?
No, for the most part, no. I've treated a couple of congressmen and senators. Their insurance covers it. I'm not saying anything. Screen Actors Guild, there's a lot of actors and directors and writers that have that live in the area. Their insurance covers it. Other than those 2, no. What's the military insurance? TRICARE for a year covered PRP for any cartilage injury. They would have you do 2 injections. They had to be 2 weeks apart. Those people did well. TRICARE got rid of it after a year. And every single one of those people are upset because now they have it in the other knee. Blue Cross, United, over the years has covered it for a 3-month period. Nobody's ever covered PRP, by the way. Well, TRICARE did. Everybody else covered stem cells briefly. And then it went away. Medicare covered it for about a year for arthritis and people that had failed everything else. And so a lot of those showed it, but no. And we'll have people say, but you don't understand, my insurance covers it. This happens all the time, by the way. There's a code for it. Every insurance assigns a code for everything. That's the way they track it. These are actually called tracking codes. And so what we show, you know, the cost of these are in the hundreds and in the thousands. When they show us the tracking code, I show people the reimbursement. When you track something, insurance is supposed to pay me $19. They don't. But so there'll be codes for it, but no. It needs to be FDA approved. That's really the secret. I know Medicare and Blue Cross did it. They were real frank. They did it to track how many people used it and what the outcomes were. So that was kind of your best thing at a study without being randomized. So it's expensive. Medicare, when they did it for that year, spent $6 billion, $5 billion. It's expensive, and that was stem cell. Yeah, it's a balance. For better or for worse, insurance is a business, so it's a balance.
So when you do one, if it's one shot, is the cost for each shot? Or is it just $500 when you're doing 2 shots?
No. It's per injection,
Per injection?
and it doesn't commit them. So if somebody needs a PRP or a stem cell, it doesn't commit them to more. So that's what I told them, and they don't pay up front. For me, if these ever get approved, you'll never hear me mention the word steroid injection again, not for orthopedics. So, thank you guys. I appreciate your patience. Sorry, this is a real dry talk. I appreciate it.